The last trimester, nature prepares the mother and the baby for birth. It just happens. Okay? No one really knows why that all of a sudden will begin to happen, but there has been some hypotheses that have been put forward as to why labor begins. Okay? These are some of the birth processes or events that take place. The first thing is the rupture of the amniotic membrane, dilation of the cervix, contraction of the uterus, separation of the placenta, and shrinking of the uterus. These are birth processes. These are some of the hypotheses that have been put forward as to why the birth process begins. Okay? Towards the end of the last trimester, there is withdrawal of progesterone and estrogen. Those are female hormones. Okay? There is stimulation of the uterus by factors such as oxytocin and prostaglandin. They stimulate the uterus to begin to contract. So these two terms here, primigravida. Primigravida means that a woman has been pregnant just one time. Okay. First pregnancy means primigravida. Multigravida means that they have been pregnant more than one time, 2, 3, 4. Okay? Multiple pregnancies. There's something that's called the that just means like successful pregnancy. Okay, you may be pregnant, but you don't have a successful pregnancy. So if I say like primigravida, one. They've been pregnant one time and they had one successful baby. So you may see that on your test, when you're doing your clinical simulations. So that's what they mean. Or if I say multi, I think there is a baby para 2. They've been pregnant many times, but they had 2 successful pregnancies and 2 children. That's what it means. Okay? So primary means the first pregnancy, multi means that you've had several pregnancies. Okay? So, although every pregnancy is different, both the onset of labor and delivery are quicker in multigravida. If you've been pregnant the first time, the second time, things go a whole lot easier, compared to the first time that you're pregnant. But every pregnancy is different. You may not have any problems with the first pregnancy, but the second one you have a whole lot of more problems. Okay? Or maybe you will have problems the first pregnancy, and then the second one you don't have anything. So, labor begins with contractions of the uterus. Contractions of the uterus. And labor is divided into three. We have stage 1 labor, stage 2, and stage 3 labor. Now, stage 1 labor is the onset of true contractions. Those contractions, when they come, will come 10 to 15 minutes apart and will last 30 to 90 seconds when they come. Okay? Contraction is nothing but each time you have contraction, the amniotic fluid will push on the cervix. It pushes on the cervix. That's what causes the cervix to dilate, the amniotic fluid. So now, if you have two contractions, that would mean that those contractions are coming 10 to 15 minutes apart, and anytime they come, they last 30 to 90 seconds. If that is not the case, then you have false labor or false contraction. Now, false labor is called Braxton Hicks. So if you have contractions that are coming 20 to 30 minutes apart, and each time they come, they're only lasting 3 seconds or whatever, that doesn't fit the definition of real labor. So that would be Braxton Hicks. Okay? But now, with two contractions, the cervix will begin to efface and dilate. Okay? The cervix will begin, I have a picture I'm going to show to you. The cervix will begin to efface and dilate. Now, effacement means distortion and widening. Okay? No, let me say that again. It's distortion and the thinning of the cervix. Effacement is thinning and stretching of the cervix. And then dilation is the widening of the cervix. So anytime the contraction comes around, the volume of the amniotic pushes on the cervix. Like that. So that causes it to efface and dilate. Okay? Stage 1 labor lasts 7 to 12 hours in multa gravida, the second pregnancy or the third pregnancy or the fourth pregnancy, and 16 to 18 hours in primary gravida, the very first pregnancy. So labor goes longer in the first pregnancy. Okay, so now if you look at the picture here, is it showing? Well, it's not pointing. Okay, so this is the cervix here. Okay, and this is the vagina. So this is the end of the cervix to the beginning of the vagina. The other end of it is attached to the fundus of the uterus. Okay, so now you can see here the cervix is closed. Okay, so down here you can see where it has. See how thick it is coming down here. See how thick the cervix is. So effacement means the thinning of the cervix. See how it's thinned down here, and then once it thins down, it will dilate. So this is dilation. So this is 5 cm dilation of the cervix. This is 1 cm dilation. Okay. So as the cervix effaces, it will dilate. Dilation is complete at 10 cm. Dilation is complete at 10 cm. So now we're going to stage 2 level. Stage 1 is nothing but contractions and thinning and effacing of the cervix. Stage 2 is the actual delivery of the fetus. During delivery of the fetus, the maternal diaphragm and the abdominal muscles are used to push. Now the mother is placed in this position here. The dichotomy is the push position. And they kind of sit up like that. And that enables them to generate more force to push. Now, there's something called engagement. Engagement is like when the baby's head is coming down to the birth canal. Okay? Once you can see their head in the maternal pelvic area, the head comes down, and you can see it, a little bit of their head. That would mean that the baby is now fully engaged in the birth canal. The baby has to be engaged before the mother will start pushing. Okay? So engagement is nothing but the position of the head in relation to the maternal pelvic area or pelvis. Okay, it is at 0. 0 means that the baby's head is in the birth canal. Any questions about that? Now, so the baby is supposed to come down with their head. That's the normal position, head down, head down, okay, coming down. So that is called the vortex position. The vortex position is head down, and that is the normal way that the baby should engage in the birth canal. Okay? So usually the baby's head will come out first. Okay? And then after the baby's head comes out, the next thing that should be born is the shoulders. Okay, so once the head comes out, the baby rotates internally. Okay? The baby usually rotates internally, kind of like bend like this. Okay, one shoulder comes off, and then this one here comes out. So once the shoulders come out, the rest of their body just exits the birth canal very quickly. Okay, so it's like the toughest thing to be born, is the baby's shoulders. Okay? And then that was the stage 2. Stage 3 is expulsion of the placenta. Now the placenta is the afterbirth. After the baby comes out, the uterus will continue to contract until the placenta comes out. Okay. Sometimes the baby may be placed on top of the mother's breast. What that does is to intensify the contraction of the placenta by the release of oxytocin. Oxytocin is a hormone that causes the uterus to contract more. Okay? So the uterus contracts more until the placenta is born. Manual pressure on the mother's abdominal walls may also help. Doctors may push on it a little bit to intensify contractions. Now we'll go to tocolysis. Tocolysis is stopping labor. If it's premature labor, the baby is not up to 40 weeks, or at least 38 weeks. The doctor may not want it to come out yet unless the baby is having some problems or the mother is having some problems. So there are things that we can do to stop premature labor, okay, prevent the baby from coming out prematurely. So premature labor is in high-risk patients. Let me say this again. Premature labor in high-risk patients is 40% with 20% rate of premature delivery. Tachylysis is employed when premature labor threatens premature delivery. Okay? You have Braxton Hicks, and the baby is trying to come out, and then we're going to do tachylysis, stopping labor. These are the different ways that we can stop labor. We can administer, a respiratory therapist can administer terbutaline. So now terbutaline is an adrenaline. It belongs to the same group with albuterol and Zopinus. So you may be called to come to the delivery room or whatever, to administer terbutaline to a pregnant woman who is having Braxton Hicks. So what this drug here does is to relax the smooth muscles of the uterus. It stops the uterus from contracting, and in that way it stops labor. Some of the side effects of using terbutaline, like I said now, it's like albuterol and Zopinus. It can cause tachycardia in the mother. Because it's tachycardia. Albuterol races your heart. This drug, being in the same group, can do that as well. It can cause hypoglycemia. That's another complications of albuterol. This drug can do that also. It can cause a hypokalemia. That's another side effect of albuterol. This drug can do that as well. It can cause anxiety. Albuterol will cause that as well. Nausea and vomiting, albuterol can cause that as well. Okay? And now the baby may develop rebound hypoglycemia. So the baby's blood sugar can go down as a result of the mother being given terbutaline to stop labor. Any questions? We can give the mother magnesium sulfate. Magnesium sulfate is an anti-convulsant agent. Again, what it does is it decreases the contraction of the uterus. It stops the uterus from contracting prematurely. One of the greatest things about I should say one of the worst things about magnesium sulfate is that it can cause decreased muscle tone. Okay, the baby comes out, they may become limp. Okay, it can cause drowsiness. It can cause decrease in serum calcium level. We can use a drug called indomethacin to stop labor. Okay. Indomethacin inhibits the production of prostaglandin. The prostaglandin causes the uterus to contract. So when we inhibit the production of it, it doesn't contract. Okay? Side effects in the fetus. Constriction of the ductus arteriosus. Now, we don't want the ductus arteriosus to close when the baby is in there. But we do want it to close once the baby is born, because the baby has to make that transition. If it closes in the womb, it means that blood flow to the aorta will be impeded. So that's kind of bad there. It can cause pulmonary hypertension. the blood pressure on the right side of the baby's heart can go up. That's pulmonary hypertension. It can cause reduced urine production, and it may cause small bowel obstruction. We can use another drug called nifedipine. Nifedipine is a calcium channel blocker. It is a vasodilator. It is also called Procardia. Procardia is another name for nifedipine. So they can get that as well to stop labor. Side effects: maternal nausea, flushing, headache, or dizziness. Okay? And then it may include decreased umbilical blood flow. Decreased umbilical blood flow. Indications for tachycardia: well, when do you need to stop labor? Stage 1 labor begins before 37 weeks. The baby may be trying to come out earlier than normal. At least 38 weeks is what we want. When there is placenta previa present. Now, placenta previa is like the placenta is blocking the cervix. The placenta is blocking the cervix. Usually some mothers will have bleeding with that. Once it blocks the cervix, it makes it very difficult for the baby to exit the birth canal. Okay? Now we go to dystocia. Dystocia is prolonged labor. Prolonged labor, where labor is lasting for a very long time. Contractions have been going on over 24 hours. The mother still has not delivered the baby because of some problems. Okay? There are 3 factors that can cause labor to prolong, go longer than normal. The first one is what they call the dysfunction of the uterus. The uterus is not contracting well. You may be contracting, what's the word there? You may be contracting very actively, or it may not be contracting enough. So it is over-contracting or maybe it's under-contracting. Okay. When it's doing that, more than likely there's hypoxia in the tissues of the uterus, which is causing it not to contract the way it's supposed to contract. The result is that the cervix will not efface and dilate the way it's supposed to efface and dilate. So that will prolong the labor. The next thing is what they call cephalopelvic disproportion. Cephalopelvic disproportion. So what that means is that either the baby's head is too big or the maternal pelvic opening is too small. Okay, cephalopelvic disproportion. Now, babies that have hydrocephalus is like when they have big head as a result of all that fluid in there, okay, retaining in their head. It makes it difficult for the head to go through the birth canal. Okay? And then the next thing is depending, like Asian women. Naturally, Asian women have small pelvic opening. So the majority of them always deliver with C-section. okay? Especially when they're diabetic. If a mother is diabetic, the baby tends to grow bigger than their gestational age. Okay? And if that is the case, when they have big head, or the maternal opening is too small, there's a procedure called episiotomy. Is like they make a little cut at the lower end of the vagina so that they can increase the size of it a little bit so that the baby's head will be able to come through it. Any questions about that? Oh, the third thing is abnormal presentation. Well, normal presentation is the baby coming down to the birth canal with their head. But they can come down with other body parts, and that is called bridge. Any other way that the baby is presenting in the birth canal other than head down position is bridge. That's bridge presentation. That will prolong labor. Okay, that will prolong labor. So we have different types of bridge presentation. We have what we call the shoulder or the transverse line. So in this case here, the baby is perpendicular to the back canal. Okay, so this is the back canal there, and the baby is that way. Okay, coming down. Your body coming down. Okay, it's not going to fit in there. All right, and then we have face or brows. The head enters the back canal in such a way that the seizures cannot override. So their head is supposed to be straight down in the back canal. But if it's coming down like this, then it's very difficult for the seizures to overload. They don't come out very easily. So it's supposed to be very down like that, pointing down, coming down to the back canal. But if their face is up a little bit and they're coming down, that will make it difficult for them to go through the back canal. And then we have footling bridge presentation. One leg comes out first. Can you imagine that? One leg of the baby comes out through the back canal, and the rest of the body is still in there. And then we have frank bridge presentation. The buttocks with legs flexed up. So there are two legs flexed up like this, and their arm are this way, and their legs are that way too. Okay? And they put us in the back canal. That will not work. And then we have a complete bridge. This is where their hands and their legs are flexed down like that. Okay, their legs are flexed down like that, coming down. Okay, so bridge presentation will delay level.